Well, greetings, everybody. Welcome to the first concurrent session that we have for the Health Informatics Conference. My name is Dr. Elizabeth Kalb, and I'm part of the planning committee, and I'm also on faculty with the IU School of Medicine. I am very pleased today to introduce Dr. Tricia Baird, MD, FAAFP, who is Chief Medical Officer for St. Mary's Care Partners in Evansville, Indiana. She leads clinical integration for St. Mary's Health, including a clinically integrated network, MSSP and BPCI. She practices family medicine and is particularly interested in patient engagement in chronic disease management. I'm also happy to tell you, even though it's sort of a HIPAA violation, but not, since I'm telling you this, is that she's my personal physician and does a decent job with a moderately compliant patient. She can have her own stories about that one. And she also is a graduate of the IU School of Medicine's Evansville Center, as Dr. Aldrich can attest, who teaches microbiology and immunology. So I will turn that over to Dr. Baird, and welcome and thank you.
Thank you. All right. We do not have a big enough room that I need to be mic'd for us, but apparently they're recording this. So, see what happens if I turn my head. Good morning. As Dr. Kyle mentioned, I was born and raised here and educated here in Quebec. So I wanted to take a moment this morning after we get a little more familiar with each other to kind of set the stage and then present a recent study that excited a lot of us, really speaking to a conversation that's being had at a national level about how to find patients, because so much of how to find and manage complex chronic disease involves IT and its setup. And where the future of that might be going. After that's in context, understanding what this Denver Health study showed us really gives a window into where we all might be thinking about health and IT development for the health sector. So before we start, by a show of hands, who are students of some kind who work in healthcare now? Okay, who works in IT now? Okay. Is there anybody who didn't raise their hand? And what do you do? Okay. Okay, very good. All right, so in my mind, I was sort of thinking of the people who can find a motherboard or a SIM card in a cell phone, the people who actually touch folks therapeutically, and the people who are learning how to do that. So I think we've got those groups in the room. All right, so I will start with one other thing. I'm not going to answer all the questions I ask by the end of this talk, so I want to have people start throwing out ideas and get used to thinking, because some of the first questions we do know a lot of the answers to. As we move through this hour, I don't know the answers to all the later questions. Nobody does. So if we get used to the process of thinking early, we can keep thinking through this talk. So, our world is changing. Let me offer you a thought from the chief economist of Google, who said this 18 months ago, talking about the volumes of data. A billion hours. That is not right. I wrote it wrong. A billion. Is hours. A billion hours ago, can you believe my own quote, Homo sapiens emerged. That's how much a billion is. A billion minutes ago, Christianity began. A billion seconds ago, IBM released the personal computer. A billion Google searches ago was this morning. The amount of compression to get to a billion is oppressive. Makes it hard for me to breathe sometimes. And that's why IT and healthcare have become so intimately involved, because computers can do one thing or 10 things really fast over and over. They can perform repetitive functions for us over and over, but they can't recognize patterns unless we tell them a pattern to look for, and that's just another repetitive function. So, strategically, what's the interface between the pattern recognition we can ask a computer to do from the data it can extract or the algorithms we can give it, so that put in our hands, there's a pattern there that we recognize and act upon. Does that make sense? At a very high level, that's the intersection of the Venn diagram. So today, we're going to talk about, these are complicated sections, what, why, how, where, who, and our future how. So, to set the stage, what are we talking about? Why do we need to work differently? How do we move forward? Where do we need to provide care or interface? And who gets loaded into this system? Then the future how will be up to you. So let's do some definitions and level set first. Kim spoke this morning about some of these topics, and as you can tell, everybody views it through their own lens. For the purposes of this hour, value-based care is to increase quality or decrease cost, or ideally do both at the same time. We'll talk about that more in a minute. By the way, why do I keep talking about money when I talk about good value care? Because patient satisfaction can be subjective and not always correlative. So if I give somebody a whole bunch of pain medicine, they might be really satisfied with their care, but that may not be the best thing for them in the short or the long term. Clinical outcomes are another metric we try to use, but mortality happens to 100% of people that are born at some point. Just because somebody dies doesn't mean you did something wrong, and just because they live doesn't mean you did everything right. So that's a little bit difficult. The other thing that happens when you start to punish clinicians for bad outcomes is that some clinicians simplify their report card by not taking care of anyone who might have something bad happen. We call that cherry picking. We would like to avoid cherry picking. I don't know why. I like all cherries, but anyway, we really want to discourage the sense that I can make you look really good if you make your denominator easy. So we got away from talking about outcomes as the bottom line metric. So what else would we talk about? To some extent, a lot of these conversations were started by payers who were conversing with us in dollars. And if you think about how you search for things on Amazon or how you shop for Christmas gifts, somewhere high on that list was price. That went into ease of acquisition, that went into time spent as well. If I make you sit in the waiting room for 6 hours before I draw your blood versus I get you in and out in 10 minutes, you spent time, and that time is money. So it becomes a unifying metric. This is not all about money. This is it should be a person-centered approach, or you didn't get all the way there. Even you didn't get all the way there with the dollars. But just for a disclaimer, the reason we keep talking about money when we talk about value is because it's something extractable and measurable. But I am not trying to convince you to keep active in clinical practice for money. So let's think about, for a minute, this quality and cost piece. Okay, so if we had activities that decrease cost and increase cost, and down here quality, so clinical outcomes, activities that decrease quality and increase quality, what kinds of things would you put in one quadrant or another? I have some thoughts, but anybody want to make me go first? So clinical integration or value care should be cost, quality. For all the math people in the room, the dependent and independent variables are now lined up. Okay, so clinical integration is the sweet spot here, and that's more and more what we're going to talk about today. So all the things that decrease cost and increase quality. Can you think of anything that might increase cost and increase quality? Like, what kind of technology? Imaging systems. So let's say instead of guidelines for MRIs, we did one for everybody. That would increase the quality of our screening accuracy, but it would also increase the cost quite a bit. in the same fashion, colonoscopies for everybody, like everybody under 50. We'd find a few more colon cancers, or mammograms down to 25. We'd find a few more breast cancers, but what would be all the extra important involved in that? Anything that would decrease quality and increase cost. This is anything you were ever told not to do. So like repeating an A1C, hemoglobin A1C is the diabetes test that we do every 3 months. If you would do an A1C monthly, it's not going to tell you a whole lot as it calibrates. That's a little more blunt force. Let me do an IT example. Repeating, this is a popular one, repeating a TSH because I can't find it in the IT system, and I don't want to go look in the other one, so let's just do it again.
Well, I would go with the piecemeal system that still is in healthcare, where you can literally have people dealing with cardiologists, pulmonologists, and endocrinologists, and none of them are talking to each other, and they're all running similar tests, doing similar results, and there's no coordination.
So let's call that silo via IT. That's a fun game. And because sometimes the person can tell you what has happened, so they can tell you approximate date and location of care, and you can't access it. The real nasty one in this quadrant is you could access it, but it takes too much time. And we see that a lot. Other thoughts in that quadrant? What about low quality, low cost? I'll give you a hint. HMOs in the 90s were famous for all kinds of things in this bucket that made people angry. Any ideas? So decrease your staffing, which decreases availability. What else? Gatekeepers. Thank you. Gatekeepers. Raise your hand if you know what a gatekeeper is. Okay. For those that weren't old enough to participate in healthcare or to get EOBs in the 90s, gatekeeping is when the patient and the clinician think you need something and somebody in the insurance company says no. And not for a clinical reason, because it's not in their payment protocol. I will give you a couple of examples from socialized healthcare outside of this country. In Canada, if you need a cardiac bypass, a CABG, they may determine that you need a CABG, but they put you on the waiting list and you get there when you get there. So in the US, we do the heroes version of, you have a widowmaker lesion, we're going to rush you to cardiac surgery tomorrow. We're not letting you go home. In Canada, they would say, you have a widowmaker blockage in your heart. Well, you're up for surgery in 10.5 weeks. Go home, try not to do anything. If you're alive in 10.5 weeks, we will open your circulation. In England, if you need dialysis for the first time after the age of 55, you don't get it. Because they have calculated that if you have that it's an implication that you didn't take care of your chronic disease. So chronic diseases that go on to affect your kidneys will lead you to dialysis, and they set an age of 55. So they have nationalized health care, but they will flat deny you based on age. That is decreasing cost, but most people would say that decreases quality. So different strategies around the world to do that, but does that give you a better sense of what we mean when we say quality up and down, cost up and down? Okay. Population health management is value-based care for a defined set of people. And there are 3 basic types of people we might try and draw a circle around. So you can try large numbers of well patients. That can be a challenge. Everybody would like to take care of that group. It's like teaching honors kids. It makes you look like a good teacher because they're smart kids. I would like to take care of a bunch of healthy people, but there's been a lot of conversation nationally about whether 27 and 28-year-olds who can't be carried on their parents' insurance feel like they need to pay a premium to be in the accountable care insurance offering, or whether they'd rather pay the tax penalty and go Baird. Go Baird is the phrase for no health care insurance. Lots of adults have done that for a long time as a strategy. They can also be difficult to engage in the old model, but they're willing to be engaged in a much different model if you develop the IT to do so. So that's an IT strategy. Small numbers of sick patients. You can wrap your arms around dialysis patients who tend to be an expensive group of folks, but if you reduce their overall cost and care, and they have a lot of duplication in their care, so it's possible. If you reduce that by 1 or 2%, that's 2% of a much larger bucket than 2% reduction in a very young, healthy population. You can take on folks with mental health diagnoses, either very disruptive, overt diagnoses, or folks whose postpartum course is complicated by depression, or whose diabetes management is affected by their anxiety. Cancer patients, as was discussed. Although I didn't hear Kim say it, if you would like to Google, if you Google the oncology medical home movement, you will find a ton of information about clinicians trying to develop a care model that fits that very acutely complex care management setting, and think about how IT will lay over that. And then all people within a certain payer type. So if Berry Plastics wanted to approach all of its insured lives, so that's the people who take insurance from them and their beneficiaries. If Deacon's Health wanted to wrap its arms around all of its associates and their insured lives, if St. Mary's wanted to wrap its arms around all of their associates and insured lives, if the EVSC wanted to wrap its arms around all their associates and their insured lives, and I just named 4 local corporations who are doing just that with a concerted healthcare approach, that can be tricky because you can be an associate who works at St. Mary's who accesses insurance through your spouse. So you can run the plan and not be a covered life. You can have people who need care but are not on campus because they are the children and spouses of your associates. So you can't just open up a care location and force everyone to participate in that on campus, or for EVSC, they have many campuses. For Baird, they have many locations because some people do you the honor of driving 45 minutes or an hour every shift to work and their families back at home. And in our area, a tri-state home, which gets into some nursing practice restrictions that are to be considered. There are market products, state payers, which are Medicaid, and federal payers, which are Medicare. And these things are in your packet just because these terms tend to bounce up a lot. And so just so we know where we're going with things. This is the Medicare. This is the very bottom line of my previous slide, kind of exploded. And many of those lines in the previous slide can be exploded. There are 3 kinds of Medicare. There's Medicare Advantage. It's a more commercial product. Inside of Medicare Advantage, every Medicare Advantage plan talks about a STARS program. That's a federal rating to make sure that the Medicare beneficiaries who access their care through a Medicare Advantage plan, a commercial plan, are getting a quality plan. So they judge on a number of folks in that plan that get preventative health measures, the number of people who have eye exams if they have diabetes, the number of people who get colonoscopies, the number of people who get cholesterol annually, the number of people who have high blood pressure measured and hypertension managed, those kinds of things. Managed Medicare, and there are financial incentives for the offices and health systems in Medicare Advantage who do a good job contributing data for the STARS program. I said that very carefully. Just because you do the work right doesn't mean you have it to present. There's another IT opportunity. So if you do the work and you put it in the place that it can be searched, extracted, and turned in, doing the work isn't the end of your job. Putting it someplace that can be found later is also part of that job. That gets turned in, and then the government feels reassured that their beneficiaries are receiving care. This is a level of play far above what I actually want to decide for a person regarding the management of their illness. Managed Medicare is a long talk for another day, and traditional Medicare, in general, the Accountable Care Act or Obamacare programs apply to traditional Medicare patients. The MSSP, these are some of the initials that Dr. Cal read off. The Medicare Shared Savings Plan is what most people refer to when they say we're an ACO. Mostly they mean an MSSP. That is all traditional Medicare patients of certain primary care doctors. Everything that you do to everything that anyone does to them for a 3-year period. And bundle payment for care improvements are not based on what doctor you see, but based on what problem you have. So the joint replacement bundles, anybody who has an inpatient stay for joint replacement, then what is their total cost of health care for the 30 or the 90 days after they are discharged. Pneumonia is one you can manage. A lot of the cardiac interventions, including bypass surgery, are ones you can manage. Acute renal failure are ones you can manage. And these are small slices of a pie of population health management. And even a small slice is pretty hard to eat in one sitting. So we're trying to learn what we can from these pieces. Right now, CMS is getting a lot more successful reporting, successful outcomes out of the bundle payment work than they are out of the ACO work, but they're trying to move through both. All right. Let's move on. Why? Why is this work necessary? Why are we working on trying to coordinate better? Can we just go back to Doc Baker and I give you a chicken and you give me a shot of penicillin and I go home? I think it's more complicated than that. And now we are at the point where 40 to 50% of our chronic disease patients are at their goals, at the the National Blood Pressure Association requirements, at the desired diabetes, blood sugar control levels, and knowing that 3 out of every $4 we spend on healthcare is spent on something we could treat, and many in those $3 we could prevent, that not every one of those patients in the first line could get to goal, but the vast majority of them. Here, the 80-20 rule starts kicking in over and over when we look at this. 80% of our dollars are spent on treatable conditions. 80% of the people who aren't at goal could get there. So how do we do that? There's a big opportunity, but now there's a big team because of the broader scope. Look at all the people playing along. And often, these last 3 people are the same person. When they're not, you find them up here a lot. So how do we keep all these folks on that page? The scope is bigger too with what we're asked to do. We have to finish all these tasks if we're to claim success. The bottom 2 lines are my best way to describe the difference between fee-for-service medicine and population health management. So in fee-for-service medicine, which you can think of as come and get it medicine, if you can get through my phones, you're available in my limited availability, you can make it into my office and you come sit in front of me, I will do anything I can do while you're sitting in front of me. Nothing on my prescription, nothing I write on my prescription pad will get your utilities turned back on, will get you a ride to an appointment, will change the fact that one of your children is taking money or medicine or time resources from you that you can't afford to give. So come and get it medicine, fee-for-service is I can fix anything you can that I have a tool for, but I don't have all the tools I need. Population health management is a much bigger ask, and what it takes to get to that other 20% of folks and solve the other 20% of their problems takes different thinking. So this is the familiar cycle. Again, our settings, our solutions, our time frame, what we're comfortable with. So if you are an old dog medicine, moving from this to something that looks more like what Kim was asking for this morning, feels like that. But we do need fresh minds and new thoughts and exciting approaches. So this is the point where the questions get bigger and the answers get slimmer, but they're pretty cool answers if somebody can come up. So, we know from our why section previously that everybody needs to come along. Clinical people, non-clinical people. But what are patients thinking? Understanding this next section we're going to talk about helps explain some of the behavior we see from them today as they go through this old model, this old cycle. And we know behavioral health issues are a huge component of clinical outcome success. From a clinical perspective, the word non-compliant gets used a lot. I don't like that for a bunch of reasons. I don't like non-compliant because that implies a relationship that's never going to change. On a whole other level, I've come to know that nobody really gets up in the morning and thinks about me that much. Nobody got up this morning to be hypertensive, to ruin my day. Nobody's trying to get their blood sugar too high so that my quality measure isn't right. They don't put that much thought into us. They're thinking about them. So what questions are they thinking about for them that we might be able to help with so that we have space to meet in the middle? Because I meet a lot of busy people who have very competing agendas, and if they had 4 more hours in their day, they would add activities, but how do we get them to 2 or 4 more hours in a day? So let's think about a couple cuts of their agenda. This is a slide that many of you have probably seen, but is a good way to illustrate where we can find people now. So now we can find people anywhere that they put medical claims, but we're reliant on the speed of the medical claim. So I can see you probably 30 days after you fill a medicine at the pharmacy. I can see you probably 60 to 90 days after you go to a doctor visit. I can see you about 30 days after you get an image, about 60 days after you see a physician or have a procedure, 90 days after you come to the hospital or come back, about 60 days here. A lot can happen in 2 or 3 months. And it is not very person-centered for me to rush over to Melissa and say, oh my gosh, I found out you were just in the ER 3 times. Do you need help? And she says, yeah, that was 2 months ago. A whole bunch has happened between now and then that I can't see, and that makes it that we can't figure out who to send or what we're sending them for. Patients have many needs for their attention. And this is something I touched on earlier. That list on the bottom, these are all things that people might ask for in the office. Usually they don't say it because they know I can't give it and it's embarrassing to ask. But many people standing in this building today have needed at least some of those things, at least some of the time in their lifetime. And we're pretty lucky, highly resourced individuals. But what if you do need these things and you're afraid to say it, or you say it and we can't fix it, or we fix it temporarily and you lose these things again? I practiced in rural central Indiana. I absolutely had people who did not have a refrigerator in their home, but they knew how to keep milk cold. So when I gave them amoxicillin, I would say, put this where you put your milk, and they knew how to do that. But it didn't help unless I know which of my patients can't read when I hand them patient education, and I know who doesn't have a fridge when I give them antibiotics. And it expands exponentially. Where are they mentally? I could talk to you about this for hours. This was my research and residency. And if you want to Google, after you Google oncology medical home, Google stages of change model or Dr. Prochaska, and there's a whole bunch that goes into how you decide. You can apply this model to picking a boyfriend, buying a car, making a healthcare decision. It walks you through mentally how you decide a lot of things. But we want to find people fast enough that they're in this preparation to action stage. They're thinking about baby steps, and they have short-term changes in place. When I run up to Melissa 2 months after she was in the ER, she's in maintenance, wherever that is. I feel better, I don't need you, I'm scared, but I've developed a support network around me that doesn't include you because you're late to the party. Or I decided to keep going with my cycle of ER, hospitalization, I don't feel well, I've felt so bad for so long, I don't remember what it feels like to feel good, but boy, it seems like a lot of work to feel good. So I've given up hope, I don't think it's going to happen for me, I'm just going to stay in this cycle. That's going to come into play with the super utilizers in a minute. All right. The last thing is, they told us in medical school over and over, you will never make a diagnosis medically that you don't think of. Differential diagnosis sometimes involves those really long lists that you can find online too, that we work through. You have to think about what might be the problem, or you're never going to tag that as the problem. So again, are we having these conversations in the interaction? Are we set up to do this in the office, which is more of a medical home than almost anywhere? Do we do this in the inpatient environment? Do we do this in urgent care? Do we ask what their barriers are? Do we have the skills and resources to make a plan? If we don't, we'll never get to the work to help them transition fully and wholly back to their regular lives. Because truly, I firmly believe almost everybody we interact with wants to get away from us and go back to whatever they were doing before they were with us, right? One of the best parts of all three of my deliveries was, after I had my kids, was stepping into my house. I want to go to my house. We get people to check out of the hospital before they're done having their biochemistry readjusted because they want to feed their pets. Not uncommon. Who matters to them is their support system. All right, so these are the things we would be looking to do to an electronic medical record. I use that very broadly. So if you have a social media app that helps track barriers or helps you communicate, or don't think about, a laptop in the office, old style EMR. So if you're going to be an IT solution that helps with healthcare, how timely can you be and how accurate can you be? Those two are trade-offs. So a lot of that, I can see you in 60 days, I can see you in 90 days. It's because I can see you based on claims. And what happened to you doesn't change after that claim is filed. If it's wrong, it stays wrong. If it's right, it stays right. But whatever it is, it is. If I use your chief complaint when you come into ER, I'm only about 20% right when we get to final billing. If I use the admission dictation, I'm only about 40% right. And if I use the discharge dictation, I'm only about 70% right about final coding. And the payers judge our behaviors based on final coding. Those dictations don't come out fast enough for me to be at your bedside either doing anything. The discharge dictation could be in my hands a week after they're home. And a week later, again, they're starting to pool those solutions and resources. So if I didn't get myself into your quality world, into your possible solution world, I'm late to the party. And again, a person-centered approach. Who cares? I don't care if you want to help me 2 weeks after I needed your help. I want you to be available when I don't have an answer. Once I have an answer, I have to undo it to put your answer in my blank. And that's a bigger ask. And absolutely, if we were fairly accurate and fairly timely and focused on each individual's needs, it would be much better engagement. All right. When I look at this, I see IT, identification, and getting me to the front door, and then population health management success. So again, not to beat a dead horse, but this idea of IT can help us get to the right doorstep, and then it has to be touch from there, personal touch from there. But there's a lot of room for improvement today in being on the right doorstep with the right person holding the right thing. So, Denver Health impressed a lot of people who think about healthcare management when they published their study last fall, looking at a 24-month period of, they have They have almost 250,000 lives. They have 214,000 lives inside of the Denver Health Network. It's a large geographic network, so they can follow people who move inside of the region. And they track super utilizers. There are lots of other nicknames for these folks. I think super utilizers is a pretty fair name, so we'll stick with that. These are people who have had 3 inpatient stays in a 12-month period, or 2 hospitalizations with a standing mental health diagnosis, because mental health can really complicate the work. In the bucket of people I'm going to show you, inside of their whole population, there were 1,600 people inside of that final population. And 3% of their population created 30% of their total healthcare spend. So this is real live data. They could have collected this from our backyard. Their results and their cuts look very similar to what we experience as far as percentage and love and interaction today. So, and I have talked to people who function in and out of the Midwest and all kinds of other settings, and this data was very representative of what we see across the country. So what I want to do, instead of talking about 1,600 people and percentages, which makes my eyes go across, I'm a simple person, so we've narrowed it down to 20 people. So these 20 people represent those 1,600. Does anybody have any guesses where the rest of the time these people are going to turn into different things to represent the segments they found in the study? Anybody have any guesses what's going to happen to some of these people? So these were all people who were in the hospital at least 3 times in a 12-month period. But many of them had that early in the period, so they're following who fell out of the group, did new people come in, or was it the same 1,600 people 2 years later who were still coming in the hospital? So think about somebody who was in the hospital 3 times in a year. How many of them do you think life changed for in the next 2 years? How many of them fell out of that bucket, stayed in that bucket? What happened to them if they fell out? What do you think happened? Some of them died. Repeated the process. So some people stayed. A lot of people, a few people. Kept running cycle. Okay, good. I died. That was my first. Oh, they get sick long enough. Don't stay with us. What else? Okay. Left of the fence. They're out of the population for a variety of reasons. What else might have happened to them? Or what happened to them? What was their thing? Were they all terribly uncontrolled diabetics? Did they all have cardiac bypass surgery? What happened to them? Some of them might get well. That actually might happen. What else? What else happened? To your point, so that point is not lost. There were about 1,600 people in that bucket at the beginning of the 2 years, and there were about 1,600 people in the bucket at the end of the 2 years. If you walk away from this talk with one thing, it's that let the computers do the repetitive work and let humans do pattern recognition. But if you learn anything else, it's that these are different people. At the end of this time, the only person who's going to be in this bucket, who was in this bucket the whole time, is this guy up here. 1 in 20, only 5% in that original 1,600 were still in that N1,600. So we tend to talk about hypertensive people, and that's true. If I have 300 hypertensive people I was working with in 2013, I'm still working with about 300 hypertensive people in 2015. But they're different people who expect a different relationship. I have to make friends with 95% of different people over a 2-year period, and that changes this IT churn, right? So just because I had a baby 5 years ago doesn't mean that the postpartum woman you're talking to now is me. Does that make sense? That was a huge aha for Denver Health to prove on paper that these populations keep rolling, that one person is not every person, and that each individual deserves a right and an introduction to their healthcare. So, we're going to watch that guy in the top. He's going to stay blue. Everybody else is going to start to change here. 10% of the people came in and out of the bucket, in and out, in and out, in and out for the whole 2 years. So I guess actually 15% of them were somewhere near the village of that population at the end of the time, but 15% is a pretty small number for 1,600 people. I like to think of these guys as the hokey pokey crowd. In general, what kind of diseases are we talking about? Diabetes, having a heart attack, heart failure, COPD, renal disease, multiple sclerosis. There are lots of diseases that come in and out. 2 of these people had one-time health issues involving trauma. So they had a car accident. A popular story this time of year, they fell down an icy back porch steps. I have not yet had that, but almost every year I've had a trimalleolar fracture from somebody who doesn't have osteoporosis, just took a really fast slide down the steps. Having your legs separated, having the bones in your legs separated involves some surgery and can involve some complications afterwards. So don't think of a bunch of old people who haven't taken care of themselves for a long time as the people in this bucket. One person of these 20 had a one-time health issue that was non-traumatic orthopedics. We translate that as joint replacement. They had a joint replacement that had bad sequelae. And we know that even the best surgeons have patients who don't get range of motion. They might get infection in the joint. Things happen. It doesn't happen often, but it happens to somebody every year. And so that's what put them there. The next person had a one-time medical issue. So they had 3 hospitalizations and then fell out of the bucket and never again, to be replaced by another one of those 20 who had a similar one-time health issue. Things like pancreatitis, stroke, pneumonia with sequelae. If you have a heart attack when you have renal disease, your heart and your kidneys keep picking on each other for a while. Pregnancy with complications. We'll put you in the hospital a couple times. These people were in and left and didn't come back. So the quarter people, the quarter blue, they were in for the first 6 months and left, and we never saw them again. They got well and went about their lives. And these folks were in for the first 12 months and then left and went on about their lives. These folks died in the first 12 months. That was my first guess what was going to happen. Only 10% of them died, to be replaced by another 10% who were going to pass away in the next 12 months. Sorry, 6 months. 10% died in the first 6 months, and the other one died within 12 months. Again, every one of these, think of these groups as ocean waves. Every one of these people that leaves is replaced by another. And there's another long talk, we could spend the day together, about people who are approaching end-of-life issues, them recognizing that, their family recognizing that, accessing palliative and hospice care, which is very person-centered, and their timing and choosing of that versus it being forced on them, a la death panel. That is not a therapeutic relationship to tell somebody that a message that they interpret as we're giving up. So again, timing is everything, being involved in that conversation. These guys, 10% of the guys moved, and we knew they moved because they asked for transfer of records, and 10% of the guys turned gray. We couldn't find them. They just disappeared. To be replaced by 10% of people who moved into the area and 10% of people who appeared out of nowhere. Let me give you a little more perspective on that. Oh, I have to mention, because we've talked about high-cost populations, in all this analysis, they only found one group that was high cost, consistently more high cost than everybody else. They were dialysis patients. 1.8% of this population were dialysis patients. The average spend of the whole population per year was $113,000 a year. The 1.8% of dialysis patients were $400,000 a year, and they were in that 113. So if you take them out and do the math, about 3 times the cost to be a dialysis patient. So you go back to that England decision not to dialyze anybody over 55 and think about what that does to their national health care spend. and why somebody might have thought that was a good idea, not staying face to face with a 57-year-old who needs dialysis. Some broad buckets I want to highlight for you of this group. 40% of them had a mental health diagnosis. 80% of them had a chronic disease of some kind. And 30% were homeless. I intentionally did not overlap the mental health and homeless populations. There is some overlap, but not everyone who has mental health issues is homeless, and not everyone who's homeless has mental health issues. The number one population of invisible homeless people are young women with children who sleep somewhere but don't have anywhere to call home. Especially these days with a cell phone in your hand, you can be pretty accessible even without an address and utility bills and the kinds of things we usually use to track people. So again, don't think a really old guy with like 5 coats on when you think homeless. There are many people in front of you. You will walk around campus today and walk past some temporarily homeless people. 2 other cuts. This is who was, the folks in the white are who was still in the bucket after 6 months. And the grayed out folks were replaced by other folks with the same problem. And at 12 months into this 2 years, you're only interacting with that 25% of people out that you already had a relationship with. So this rolling relationship building, again, has to be a key strategy of the IT development. So in 10 years, when one of you is the keynote speaker at this conference, what did you make that met this new need that was mindful of all this data we talked about today? There are some really smart people with a lot of resources that are asking these very questions. So, congratulations. You're caught up to the state of the art of the questions that are being asked today. But it really is a new world. And I don't know if we're going to solve this in 2 years, or 10 years, or 20 years, but as soon as somebody gets something global, interoperable, portable, available, that starts to work on a local geography, it's going to start to expand. And we're seeing a lot of those innovative products that solve half the problem instead of 20% of the problem, that are working well in local areas. People are starting to try them more broadly. When someone reaches critical mass, when they can solve 80% of a problem for a variety of geographies, you're going to start to see this healthcare as local thing become a little easier to solve in scale. It's well worth doing. It's really hard. So I'm sorry for anybody that you talk to who was in a different session who says, "What did you guys figure out?" Because you're not going to be able to give them a paragraph on what you did. But I thank you for thinking through this with me, because we're all going to keep thinking about it. Thank you.
Are you looking for any questions?
Oh, sure. Ask me whatever you want. If I don't know, I'll make up an answer. That was a pretty heavy topic. Sure. So when you look at spend, when you look at the triangle of patient care and spend, 5% of the patients create 50% of the spend. That statistic gets quoted a lot. Those are the high-risk patients. Then the medium risk or rising risk patients are 4 times larger of a group, but create maybe 25-30% of the spend. It depends on what community population you're looking at. Of that rising risk group, only 40% of them are at risk to become high risk, and half of that 40% will bump up in the next year. So this conversation is being had right now, and we're having it kind of in secret pockets. Somebody thought, oh, I'll just keep it to myself and solve it, but But in the last year, people are coming together kind of after big conference panel discussions off stage going, hey, you know, we're looking at trying to marry your Facebook likes to your medical record and seeing if that helps us find that rising risk population. Oh, we're looking at, you know, natural language processing of Instagram, Twitter. There was a Twitter poll for asthma that has been the most successful published recently. Just all kinds of crazy out of the box for how to pull in that ambulatory office-based population. For the most part, we're getting really good at case management, care management in that high-risk population, but everybody's trying to have a conversation about how to extract the right rising risk patients and what data to use to do that. As soon as they figure out how to do that, my headache starts because their need bucket is wildly diverse. Then you get into tons of social issues. In fact, just this morning, CMS challenged hospitals to reduce readmissions specifically for minority patients. That's not an isolated inpatient admission issue. That gets into that population health bucket. Do we have food deserts? Do we have complete streets? Do we have transportation access? Do we have cultural freedom to engage in those barriers in care settings? Or is there a sense that you can't solve my problem and I'm not going to ask you about it? So getting into, should we have more representational clinical staff so that there's a cultural comfort? So how much did women start talking to their doctors when their doctors had ovaries too? How much did the doctors with ovaries change the conversation about how we should approach care and not do radical mastectomies and not separate moms and babies for 48 hours after they were born? Those are much broader issues than a mandate of fix this in a month or two. And so right now the conversation centers on identification of that ambulatory rising risk group. I hope they solve it. When they finish, the big work begins of then how to address that. What kind of staff is that? Right now, our navigators, for the most part, are RNs and a few social workers, behaviorists. When you get into that ambulatory population, you may not need that high of a complexity of licensure, but you're going to need somebody who's has clinical depth to address those questions. Where does that person get that training? You know, what clinical skill set preceded, I want to treat you like I treat my mom?
On the other hand, training, I mean, with these people now, this is the way that I was thinking like 80% results. BMI comes out 25%. 25% of their traditional breast issues. So obesity has to be addressed. Sure, you got elevation. How do we do I address that?
So I will tell you that those studies come from looking at the G codes that are attached to obesity coding. And since coding that, Melissa's laughing at me, she turned me saying this thing in my office. Since coding for those extra, I mean, I could add 15 extra codes at the end of every visit, right? But then I'll see half the patients I was supposed to see today. And I'd actually rather go help somebody than file more library books or codes. So they're searching that based on that coding, based on G codes. So the coded reflection of those health addressments are far short of the actual. The other thing is, when I'm trying to get somebody to use their inhaler correctly, there is a New England Journal of Medicine article that's 15 years old that says that clinicians can only address 9 fresh questions in a visit. So if you ask me about your mom's skilled nursing placement and we want to move your prescriptions from 30 to 90 day scripts, and then we go on to talk about clinical things, I see it with families and well childs. I'll only do 2 well childs a day, because if you bring 3 or 4 kids, you might remember the last things I said, but you forget the first things I said. I mean, your brain just gets full. Well, the 9. It's good news. And sometimes I'll go out to, grab something and, okay, let's reset. Let's focus on what's important. Let's make an agenda. But that 3 or 4 main topics, and then you get lost in all you lose the first information or the middle information, the last information. You have to make some choices. And if that means they need to come back in a week or a month or 6 weeks, and you do alternating 3-month visits 6 weeks apart to address this and then that and then this and then that, so be it. But I really need your inhaler technique to be good, or you'll never be able to exercise on the bike to lose weight. So if that's what we talk about today, I may not address the fact that your BMI is 28 because I'm trying to get there. No, not at all. It's complicated. I mean, it's so complicated. I was watching Kim talk and I thought, wow, what if I used to see 35 a day, now with all the requirements, it's like 25 a day. What if 25 people, were expecting that amount of input? I'd have to get really smart. I mean, even if I did sleep, I think I'd still be out of time. That's a lot of stuff to know.
I want just another aspect of stuff, because I've been studying pathology, and this is a study, I can't quote the thing, but 20 years out, they did smoking cessation, where that still continues to be an issue. And I'm thinking something like